So good afternoon, everybody. Thank you very much for joining us during this lunch session entitled Pivotal Momentum for Tricuspid Valve Intervention. And the reason for that is referring, of course, to the trial that was just published. Actually, it was published today officially in the New England Journal of Medicine with principal investigator Paul Soraja, who is with us. And the session referred to that trial, so we will try to go a little bit deeper into the data to understand which patients were treated in the trial, but also to broaden a little bit the spectrum and understand what are these different patients, how do they compare to the real world as well, and what are the next steps. And we will illustrate this also with cases, so to make everything a little bit more live, interactive, also to have a reaction from your side. So I have, for this fantastic panel, I have to say, supporting this session, so I have from left to the right, Christian Bessler from Bad Krozingen-Freiburg, Nina Wunderlich from Darmstadt, Philippe Lourdes from Leipzig, then, of course, Nicolas Dumonteil, who will speak in 1 second, from Toulouse, Miriam Wild from Freiburg-Bad Krozingen, and finally, Paul Soraja from Minneapolis. Thank you very much, Paul. So, Nicolas, do you want to say something to our audience? It should be interactive, I think.
Yeah. And, we hope that you find all that will be discussed here really relevant to your practice. So, really feel free to interact with us, share your comments, ask your questions to the speakers, to the panel. Several ways to do that. You can stand up and just take a mic, and we let you the opportunity to talk, or you can connect through the app and write your question, and Miriam and I will be in charge of addressing that and putting that in the screen and the discussion when it's time.
Thank you very much, Nicolas. We have 45 minutes, so it's a short session, and we will start immediately with you, Nina, and you will present us a little bit what is the state of our understanding of tricuspid valve disease. Thank you, Nina.
Thank you so much. It's a great pleasure to be here and to present. So, advancing in the understanding of tricuspid regurgitation on patients' life and the prognosis. These are my disclosures. So if you look at this graphic, we can learn that the patients with a higher degree of tricuspid regurgitation, for example, on the right-hand side, we see a patient with torrential TR, that these patients have a worse prognosis on the long term. So, and if we look at tricuspid regurgitation patients, we don't have a uniform phenotype. So we may have tricuspid regurgitation secondary. This might be either to atrial dilation or right ventricular dilation, and this patient group counts for 90%. We also may have patients with a CIED-related tricuspid regurgitation or with a primary component, and this patient group accounts for about 10% of the patients. Just give you an impression, what are the different phenotypes? So, for example, here in atrial functional tricuspid regurgitation, the major mechanism is tricuspid valve annular dilation. So if you look at the patient group with ventricular dilation, so this is more pronounced in the ventricle, so the ventricle is more dilated in relation to the right atrium. So then we have the group of CIED-related tricuspid regurgitation. This is a broad spectrum. So normally in this patient, we see a leaflet structure abnormality, but on the other side, any phenotype can occur. So you can have a lead which is connected to a leaflet or which can at least contribute. So we have a lot of different phenotypes in this group. So the last group are the patients with a primary tricuspid regurgitation where you have a problem concerning the leaflet itself. So here, for example, you see a tear in the anterior leaflet. On the right-hand side, you can see a patient with a Hedinger syndrome. So also a broad spectrum. So why is it important to differentiate between different phenotypes? And here is a paper I brought to illustrate that if you look at patients with atrial functional TR, defined here as a patient group, what you see in echo with a tenting height below 10 millimeter and a right ventricular mid-ventricular diameter of smaller than 38 millimeter and an ejection fraction which is preserved, that these patients, this is a typo because right atrial area should be enlarged in these patients, that these patients with atrial functional tricuspid regurgitation, if you look at the natural cause and a medical therapy, that the patients with atrial functional tricuspid regurgitation compared to the non-atrial tricuspid regurgitation group performs better on the long term and has a better survival. On the other hand, if you're going to treat these patients with tricuspid valve intervention, the patients with atrial functional tricuspid regurgitation may also benefit more from intervention than patients which are not in the atrial functional tricuspid regurgitation group. So what is the time point when you usually treat the patients? And this is a time point where the patient has already severe tricuspid regurgitation and where the patient is symptomatic. So we have to ask ourselves if we are too late if we treat the patients at this time point. And if you look at the time point when the patients become symptomatic, they are already in a later stage of the disease. And if you look in the baseline characteristics of patients included in a real-world registry, the BRIGHT registry, the patients already at the time point of treatment have massive or torrential tricuspid regurgitation in over 90%. And as you can see here by the NT-proBNP levels, this is already an advanced stage of the disease. So does the baseline tricuspid regurgitation grade matters? And if you look at this study here on the left-hand side, if you follow the red line, these are the patients with a massive torrential tricuspid regurgitation before the procedure. You can easily see that it does matter because the patients with massive or torrential tricuspid regurgitation have a worse prognosis after 1 year. It's also more likely that the patients with massive or torrential tricuspid regurgitation have a higher residual degree after the procedure. And as we can see here, this also matters because if tricuspid regurgitation is severe or greater at 30 days, this is a red line, so these patients again have a worse prognosis. So to summarize, the prognosis of tricuspid regurgitation patients worsens with an increase of tricuspid regurgitation severity. We need a uniform classification of tricuspid regurgitation, which is already maybe not at the point, but it's according to the Genese, and it is important because, for example, atrial functional tricuspid regurgitation patients appear to have a better prognosis and to be more likely to benefit from an intervention than other phenotypes. In the real-world scenario, most patients have already massive or torrential tricuspid regurgitation at the time of intervention, and the baseline tricuspid regurgitation grade has an impact on the prognosis of the patients, and we have to ask ourselves if we might be too late if we treat the patients at this stage. Thank you very much for your attention.
So thank you very much, Dina. So I think the scene is set. So time point of treatment, heterogeneity of disease, that's exactly what we want not to discuss now in much detail, but to illustrate, Christian, maybe with your 2 cases. So can you present us 2 cases, and then we will have a discussion regarding these 2 points.
Thank you, dear colleagues. The first case I would like to share with you today is of an 81-year-old lady with a history of heart failure with preserved ejection fraction, long-standing atrial fibrillation with a history of pulmonary vein isolation 6 years ago, and a history of coronary disease with the LAD PCI 8 years ago. In June 2021, this patient presented to one of our referring physicians with worsening dyspnea on exertion and peripheral edema. He did a rough echocardiographic exam and diagnosed severe TR. And in the setting of preserved renal function, he initiated a diuretic therapy with 20 milligram of toracemide. 7 months later, the referring physician sent this elderly lady to our center for further evaluation because she had persistent symptoms, still New York Heart Association class 3, dyspnea on exertion, peripheral edema, and obviously she had impaired physical functioning within 6-minute walk distance of 188 meters. On the ECG, we observed atrial fibrillation, but under adequate heart rate control. and she had persistent tricuspid regurgitation, and obviously we were interested in the etiology and the mechanisms underlying tricuspid regurgitation in this patient. Left ventricular function and dimensions were normal. There was mild left atrial dilatation and profound remodeling of the right atrium, as you can see on the right-hand side. There was tricuspid annular dilatation, and the right ventricle had a rather normal size. There was mild dilation at the very basal part, but at the remaining sections of the right ventricle, we had normal diameters. So overall, we interpreted this phenotype as an atrial functional tricuspid regurgitation. We increased diuretic therapy. Toracemide was increased to 30 milligrams, and we added a second diuretic. We added a mineralocorticoid receptor antagonist, spironolactone, 25 milligrams, and we scheduled a reassessment after 3 months. At this reassessment, the edema slightly improved. 6-minute walk distance was more or less the same, and the patient was still reporting dyspnea on exertion in functional class 3, and she still had severe or massive tricuspid regurgitation, and that's why we went on and did an evaluation for transcatheter therapy, transcatheter edge-to-edge repair therapy in this patient. Obviously, there was no progression of coronary disease in this patient on coronary angiography. On right heart catheterization, we excluded relevant pulmonary hypertension, and the right atrial pressure tracing are shown ventricularization under deep inspiration compatible with hemodynamically significant tricuspid regurgitation. We had actually a tricuspid valve with 4 functionally relevant segments. The posterior segment had 2 segments divided by an indentation, and so we decided to go for an XTW implantation in the anteroseptal commissure, and there was 1 XTW placed rather central in the anteroseptal commissure, with the result shown on the right-hand side. The second patient I would like to present is a 78-year-old gentleman with a history of heart failure with mildly reduced ejection fraction. He underwent percutaneous transeptal mitral commissurotomy for mitral stenosis 6 years ago. He was known for atrial fibrillation, chronic kidney disease, type 2 diabetes, and peripheral arterial disease. He presented to one of our referring hospitals with a second episode of severe acute decompensated heart failure. Our colleagues at the referring hospital already diagnosed significant TR and sent the patient in acute decompensated heart failure to our center for further evaluation. We first had a look at his mitral valve. As you're well aware of, that rheumatic mitral valve stenosis may result in restenosis and of mitral regurgitation after commissurotomy, but opening area was fine, 2.8, mean gradient 3.2, and a mild mitral regurgitation after PTMC 6 years ago. However, this patient had also severe tricuspid regurgitation, but the morphology of the right heart chambers differed. We had severe right atrial dilatation, but also remodeling of the right ventricle with a dilatation in the basal, mid, and apical parts. We put this patient on IV furosemide to diurese him. Kidney function was severely impaired. eGFR was 22, and there was evidence of hepatic congestion with elevated gamma GT and AP levels. The patient stayed 3 weeks in hospital. His leg edema improved, his situs got better. We were able to transition him to toracemide, 60 milligrams per ounce. However, he was still complaining of relevant dyspnea on exertion, functional class 3, and therefore we did a repeat echo showing again persistent torrential TR, and that's why we scheduled this patient for a very timely transcatheter edge-to-edge repair with a TriClip device. Here is the result of the intervention, pre on the left-hand side, post-intervention on the right-hand side. 2 XDWs were implanted, one in the anteroseptal commissure, rather central, and one in the posteroseptal commissure, and the torrential TR could be reduced. With this, I would like to give over to Fabien again, and I think we have a discussion of these 2 cases now.
Thank you very much, Christian. I would propose that we keep this slide maybe on. Thank you very much with a summary of the two patients so that you really have them in your head. Maybe I have a question for you first, Christian. So in the first patient, if I summarize, 81-year-old, isolated or tricuspid regurgitation, not so much right ventricular dilatation, low wedge pressure, so no left-sided disease, and no hospitalization. But what you did in the first patient, in contrast to the second one, you decided to wait and to optimize medical treatment. So is that a strategy you do systematically? Because in the second one, you actually intervene, and we are complaining to intervene too late. So is that a strategy you would advise, or what was your thought regarding to this?
I think it's a quite complex decision to make, and I think we have to incorporate several factors into this decision. First of all, the clinical status of the patient is how was the clinical course of his symptoms, how is renal function, how is his response to medical therapy, is there still room for improvement of medical therapy? So I think there are several factors to consider, and given the preserved renal function in this patient and the rather controlled clinical situation, we decided to wait and to go for a more intense diuretic therapy here.
I think that's the point. The difference also between the patient, the second one at an event, was hospitalized.
Exactly.
So that's maybe. But maybe to you, Paul, regarding this strategy, is that something in the context of the trial as well that has been done in the patient? Optimize more, even if medical treatment is limited?
So in TRILUMINATE, we really made an effort to isolate the TR as much as possible from untreated left-sided valvular disease or left-sided heart failure. So the first patient was exactly how we would have managed in the trial. And I think it's important, the second patient with the MS and the RV dilatation, there's probably some pulmonary hypertension possibly related to the MS. And the MS can be easily underestimated too because of the low flow state of the TR. It's a little bit more challenging, but we would have done just like you had done. And I think the results are better not only for the procedure, but also for the long-term results for the patient.
Maybe to you, Nina, you have seen the images of this patient. So what is your feeling? Are there different etiology behind this? What did you see? What is important in the selection of the patient on the images?
I mean, Christian pointed it out very clearly. So in the first patient, we had more pronounced dilation of the right atrium. And at the level of the tricuspid valve, it was more pronounced dilation of the annulus, and we didn't see severe tethering. So in the second patient, he nicely pointed out that the patient has a higher involvement of the right ventricle, which leads to a displacement of the papillary muscles and tethering on the leaflets. So for the procedure itself, I mean, the easiest patients to treat are definitely the ones where you just have an annular dilation and where you don't see a pronounced tethering. So as soon as the right ventricle becomes involved and the tethering is going to be pronounced, it's for the procedure itself, you have to consider maybe specific things. It's getting a little bit more difficult. And what we also know, as soon as the right ventricle is more involved, the prognosis of the patient may be even worse than the patients who just have a pronounced right atrial dilation.
Nicolas.
Yeah, we already have some questions coming from you, and maybe this one for you, Philippe, coming from Dr. Eitan. Is TR truly a disease, or more globally a marker of heart disease?
It's a very, very good...
You have 5 minutes.
Yeah, that's a very, very good question. Well, what we know is that it is for sure an independent marker of prognosis, and this is independent of LV function, RV function, pulmonary hypertension, and many other comorbidities. What we haven't proven yet, and because it's not that easy, whether there is a clear causality that when you treat TR, that you prolong the prognosis of patients. And that's the task for all of us being involved in the field for the next years.
Yes, thank you. And another one I think that is crucial also related to the selection of a patient and how to put the indication for interventions. That is maybe for you, Nina, how about the relationship between TR severity at the time of assessment and volemia?
I mean, I hope I could show that that with a higher degree of tricuspid regurgitation, the prognosis of the patient is going to be worse. So we don't have clear data yet indicating at what time point we should intervene. But if you look at these preliminary data, giving us some hints that it might be better that we address the patients a little bit earlier in the stage of the disease. So we need data to support that, and we need to see how the patient progresses if we treat the patients a little bit earlier in the timeline.
Nina, maybe as a follow-up to the question about different etiology of disease, there is a question that is interesting also regarding other therapy. We talk, of course, about TriClip, but do you think, for example, treatment of atrial fibrillation in some of the etiology, in some of the phenotype, could be helpful?
Yeah, definitely. I mean, in many patients with really big right atrial, so we see atrial fibrillation in a lot of patients we are treating. So it's about 30%. So it's a very frequent observation, and especially in the group with atrial functional tricuspid regurgitation. So many of these patients have long-standing atrial fibrillation. If it's possible, you should discuss it with your EP guys, and if it's possible, to treat the patient and to get rid of atrial fibrillation. We know from the data that this is beneficial for the patients.
Philippe?
I think it also goes the other way around. Treating TR can also help to maintain sinus rhythm. So,
very good point as well. So we move now to your presentation, Paul, regarding the TRILUMINATE trial performed in the US, published in the New England Journal of Medicine. Congratulations again, Paul.
Thank you.
And we are looking forward to the results.
Congratulations to everyone, to the entire field, really. I think it's a really exciting time for TR, not stent failure. There we go.
So we move out of the session.
Yeah, yesterday we had ChatGPT helping us. This is better. Okay, all right. Fantastic. Well, so this is a recap of yesterday's late-breaking presentation, and so I'm going to just touch upon a few of the highlights for you all, and this will be obviously important information for discussion. So we know from TRILUMINATE that there was excellent reduction in severity of TR with the device. At 1 year, it was 89% to moderate or less. And we also know that the therapy was incredibly safe. The freedom from MAE at 30 days was 98.3%. So very effective and safe therapy. And we also know that in TRILUMINATE that the trial was demonstrated, the device was demonstrated to be superior to GDMT, and that superiority was driven mainly by improvement in quality of life, without differences in death or heart failure hospitalization. When we look at these patients a little bit further, I think we get a little bit more insight into who the patients were and perhaps why the results were what they were when we observed them. So here, this is the baseline characteristics of the trial, and we can see the average age was 78 years. Most are women. Most had atrial fibrillation. We can see here that in a core lab adjudicated setting, that 71% of the patients had massive or torrential TR. For the prior intervention, most of the patients who had surgical aortic valve therapy, and most of them also had prior mitral repair done percutaneously, and the heart failure hospitalization rate within the prior year was 25%. So here's some interesting data on LV and RV size and morphology and function in the trial. So here on the left-hand side, we're focusing on LV and RV size. And here in orange is when both are abnormal, and here in green is when both are normal, and then here in yellow is when one of the two is abnormal. And what we can see here is that RV end diastolic dimension, at least at the base, was enlarged in these patients in most, and that was enlarged in about 89%. The mean RV EDD was 5.1, whereas the majority of patients had a normal LV size with a mean LV end diastolic volume index of 44. And then on the right-hand side, we can see here that in most patients, the vast majority had normal LV function with an average LVEF of 59, and there was also evidence of mild RV dysfunction in most patients with a TAPSE of about 1.6. So there's also some insight into who these patients were based on the mandatory right heart cath that was required for enrollment in the clinical trial. And when we look at these, the wedge pressure on average was 14.9, so below the assumed normal cutoff of 15. And that's because patients with left-sided disease that was untreated with elevated wedge pressures, typically over 20, were routinely excluded from the study for further left-sided heart failure optimization. The mean PA pressure was 26, so somewhat moderate degree, 86% of the patients had PA systolic pressure less than 50. And we can also see that the right atrial pressure demonstrated a moderate degree of congestion with a measured value of 11 for the trial. There was evidence of some congestion in cardiac, kidney, and liver disease. So we can see here that the BNP is elevated in nearly all patients. 40% had values over 2,000. The majority had kidney dysfunction, with 48% of the patients have moderate or severe impairment. And then gamma GT, which we know is a marker of liver congestion, was elevated in most patients. Just the last two slides here, just to kind of put the trial somewhat in context here. So here we know that when we designed TRILUMINATE a number of years ago, that we had very limited data on the prognosis of patients with TR, and most of that was limited to TR in the context of left-sided disease that was untreated, and those studies here are in orange. And what I'm showing you is the one-year mortality for those patients with TR in the context of left-sided untreated valvular disease or left-sided heart failure. In contrast, over the past several years, as TRILUMINATE was being done, we can see here that a number of studies emerged, and they're in blue here. These are the studies where the patients had TR, but they had their left-sided disease managed quite well. And what we see here is that the one-year mortality rate for these studies in blue, where the left-sided disease was managed well, was about 7 to 14%, is exactly in line with what we observed in the TRILUMINATE Pivotal randomized trial. And then finally, this slide shows the change in quality of life in the context of right versus left-sided disease, with these trials on the left side showing some benefit in their primary endpoint, particularly mortality. And so these left-sided therapies included medical therapy as well as device therapy. And this puts in context, I think, the difference between right versus left. And what we see is that the change in quality of life for TRILUMINATE was right in the middle of some very key, important left-sided treatment trials. So in summary, TRILUMINATE we know is the first randomized trial for transcatheter therapy for TR. These findings, we find that, and we looked at these patients further, they had no untreated left-sided valve disease. They had well-managed left-sided heart failure when present. The LV size and function was preserved in nearly all patients. They had evidence of mild RV dysfunction and moderate RV enlargement. They had severe symptoms with moderate impairment of quality of life. The right atrial pressure was moderately elevated with essentially mild or normal wedge and moderate pulmonary hypertension. The one-year mortality was 8%, comparable device and control arms, and it was in line with studies of TR with managed left-sided disease. And the quality of life improvement was comparable to other trials that we have felt to be meaningful for established therapies of left-sided valvular or left-sided heart failure. Thank you very much.
So thank you very much, Paul. Very clear presentation. Of course, selected population of patients in the context of a randomized control trial. And now we would like to, before we go to discussion, to make a direct comparison with the real-world data from Europe, from the BRIGHT registry. You are the PI of Philip. And these data have also been presented yesterday, published in JACC yesterday. So can you summarize what you found in the real-world population?
Yeah, thank you. Indeed, I think this is more real-world. This is more reflection of what's been done currently in daily practice. In the BRIGHT study, with very few inclusion criteria and more important, very few exclusion criteria, so it's more or less almost an all-comers approach. Obviously, also there was a high effectiveness in regards to TR reduction, with 77% of patients having moderate or less TR after the therapy. This is not as good as shown just by Paul in TRILUMINATE Pivotal, but the reason for that is first, a high likelihood to reduce TR to moderate or less was not a prerequisite for this registry, but also whenever you compare different studies, different registries, and the efficacy of the therapy, you have to take into account what patients started with, and you can see that the percentage of patients with massive and torrential was really high. There were only 10% with severe, the rest was massive and torrential. And as also shown on the right-hand side in that graph, obviously when the patients start off with severe, the likelihood of bringing it down to moderate or less is much higher than those with torrential, where it is only about 60%. But don't forget, even in those with torrential, more than 80% of patients had 2 grades of TR reduction, at least 2 grades of TR reduction, and we have an indication that this is beneficial for patients. We are obsessed with reducing mortality, and rightly so. But we should not forget that we are also there to reduce patient symptoms and improve quality of life. We do have a strong signal in the BRIGHT registry that this is the case, with a clear improvement in NYHA class, a marked increase in KCCQ score indicating improved quality of life in these patients. And although this is not a final proof, again, it supports the idea that the more you reduce TR, the more benefit you get in terms of quality of life, having 20 points improvement in those with moderate or less TR after the procedure. There were some parameters indicating or predicting the procedure's success, independent significant predictors of multivariate analysis where tethering distance and right atrial volume, so both ventricular and atrial indices of right heart remodeling, and obviously the earlier you treat, the easier the procedure will be and the higher the likelihood to end up with moderate or less TR. So what's now the difference between a randomized controlled trial and a real-world registry? Well, there are several similarities in terms of age, gender distribution, comorbidities. The main differences are the higher percentage of patients with NYHA class 3 or 4 in BRIGHT, a lower KCCQ score, and a higher percentage of patients with previous heart failure hospitalization before the therapy. There's an indication that indeed BRIGHT patients presented sicker than those treated in TRILUMINATE Pivotal. Here you can see some echo parameters. Again, the most important difference is the percentage of patients with severe TR. In BRIGHT, only 10%, 90% had massive or torrential, and then in TRILUMINATE Pivotal, the percentage of those with massive and torrential was a little bit lower. And this is also to some degree supported by the fact that the gaps were wider in BRIGHT as compared to TRILUMINATE Pivotal. What we have not stressed enough today, I think, especially when we talk about early treatment, is the safety of the procedure. In both the registry but also the randomized trial, a very convincing safety profile, which obviously is the key, especially when we discuss when to treat and especially if we advocate early treatment. Thank you.
So thank you very much, Philippe. Let's discuss a little bit this comparison and this different result, and then maybe we can apply this also to your cases, Christian. So if I summarize a little bit what we have seen, I think you will agree with me, Paul and Philippe, that we have a difference in terms of the burden of symptoms between these two populations. So BRIGHT real world had more symptoms at entrance into the study, more hospitalization, and a higher NYHA class. And then we had differences in the anatomy, not so much in the dilatation of the right ventricle, but in the gap. And then, so that's a little bit the summary. Maybe, Paul, maybe your thought on this. How do you see these two populations? Maybe also, in perspective to the different context in the US and in Europe.
Well, first of all, I think it's important for us to understand the differences in the two studies as they're reported so we can have some context of the results, particularly the effectiveness of the TR reduction. But what I would just kindly remind everyone is that TRILUMINATE was a 2-arm study, and I'm only sharing with you the randomized arm. There's a good chance when we look at the single arm that it's going to look more similar to results of BRIGHT, because BRIGHT, if it were a randomized study in Europe, it could be randomized in single arm because you took all comers. And in TRILUMINATE, we hope to have a single arm data out soon, but it's the large part of the differences, I would say, is the fact that I'm only showing you the randomized cohort at this point.
But that's a very important point because you may not know this, but the patient excluded from the randomization due to anatomical reason mainly, the gap was one of them, went into a single-arm study, and that will be, they were treated as well with a
yes,
tricuspid?
And they were treated, yeah.
So that's the whole picture then, and that will be presented, I think, at TCT, if I'm not wrong?
Not certain yet, but hopefully we'll have it soon.
I'm anticipating a little bit, but let's hope. Philippe, your comment. about these differences? Do you think we can make something out of it, or it can drive the practice?
First of all, it's important to see what's being currently done and at which stage patients are referred and at which stage patients are actually seen by physicians and when the procedure is considered. I think that it is an important message that although BRIGHT patients presented later, the clinical outcome was good, there was symptomatic improvement, there was a very marked improvement in quality of life. And then, although it was not a prerequisite to have a high likelihood of achieving a perfect result, even in those with torrential, we do have an acceptable percentage of patients with a good TR reduction, and will be very interesting to see then in the other arm how the likelihood of achieving a good result, even when you thought it wasn't the case, because obviously when you have more complex anatomy, then the procedure is more complex, but even with these challenging cases, more than 50% end up actually with a very good result and have clinical improvement, and that's also one of the challenges. Whom do we treat and whom would we not treat, because we think that the anatomy is too challenging. But there's also, I guess, a learning curve, and we get better and better, thankfully.
Thank you. Nina, one question regarding grading of TR. You have seen that there are discrepancies between the registry in the repartition of more than severe, massive, torrential. So do you think this is relevant? Are we good at grading TR, or is that still a little bit subjective in terms of differing from core labs to core lab, or from people measuring to others?
Yeah, I mean, it's a difficult topic, and it's difficult to compare different techniques, but I think both studies went to a core lab evaluation, and what is evident now, so how we do the grading of tricuspid regurgitation should be more or less at the same level. So I think it just came clearly out that if the patients are treated at a later stage, I mean, the outcome might be worse. But on the other side, we also learned from the BRIGHT study, and I think we will learn that also from the single-arm study, that you can do something good for the patient. So grading of tricuspid regurgitation is a big discussion, so how to do it in the best way. So PISA was included in all the trials, so PISA is something which should be addressed, and especially in the patient, if you have a ventricular component, you should go for an angle correction, and this is done in a core lab analysis. So I think it's comparable from that point.
Yeah. No, I think we should also, and Paul, you may agree on that, we should also be careful not making categories. I mean, you had a very different patient in TRILUMINATE as well, as a large spectrum of patients, and there are tendency, but this population is very heterogeneous.
Yeah, but I think it's interesting. It is incredibly heterogeneous, but it's interesting that the KCCQ change of 2 grades is pretty consistent in terms of TR reduction. And there's a clear relation between TR grade and quality of life improvement. We see it in BRIGHT that about a 2-grade reduction is in the high teens or 20. And it's consistent in both BRIGHT and in TRILUMINATE. And so it'll be interesting to see how the single-arm data works out, but it's pretty consistent among the different studies despite the heterogeneity of the population. So.
Philippe, you want to
I just wanted to follow on to that, to the similarities, because we're focusing on differences, but both studies, and it should be stretched again, also show the great safety profile of TIR procedures. Procedural complications were extremely rare, and TIR is an extremely safe procedure.
Fabien, we have a lot of experts about TriClip in this room, but maybe it's worth also clarifying maybe more general or basic data, and maybe Paul, you can address that one. We have a colleague in the room asking whether a rheumatismal cause of a TR with very restrictive leaflet could be treated by a TriClip.
So we generally have not treated patients with rheumatic disease because of the relative stenosis and fixation, and it's pretty difficult in some patients, especially for rheumatic, when the leaflets are fixed or type 3A morphology, to get the leaflets to come together with TIR. Our experience has not been favorable, and we excluded those patients from the trial.
Okay, and then maybe, Philippe, another one for you. Is TriClip a therapy for severely symptomatic patients with restrictive cardiomyopathy with moderate to severe TR?
I think that the chances of improving symptoms are quite high, and beyond that, it's difficult to answer.
Okay, thank you. And
a short answer.
And then, I think we have a last one that is a perfect transition for you, Christian, and for presenting us the outcome of your two patients. Is this following? Is it possible that tricuspid tear in patient number 1 profile prevents him from transforming into patient number 2 profile? So
Christian, what do you think?
I repeat, yeah. Now, is it possible that tricuspid tear in patient number 1 profile prevents him from evolving into patient number 2 profile?
Well, that's a good question. We hope so. We don't have long-term data to support this assumption, but I mean, given that the possibility that we can now reduce TR, there is the hope that we can prevent such severe remodeling we have seen in patient number 2. But as said, we're still lacking good, high-quality, long-term echocardiographic imaging data to support it.
May I make a comment?
Yes.
So, sir, there is data in the TRILUMINATE 1 or EFS study on favorable RV modeling, at least in that early experience. And in TRILUMINATE Pivotal, we have a great imaging sub-study with CT and MRI that will also help address that. Because I think that we have to tie the TR reduction to quality of life benefit through a physiological mechanism. And I think we're going to learn a lot about that morphological analysis. Sorry. Yep. Did you hear anything I said?
Okay. Maybe a last short one again for you, Philippe. According to the everyday and daily use of TriClip, in your experience, in what proportion of patients with severe symptomatic TR is TriClip technically feasible?
I guess that very much depends on the cohort of patients which are referred to the center, how much you increase the awareness of your referring physicians, at which stage are they referred. So it's difficult to answer. But previously we focused a lot on the gap. I think the gap these days is not that important anymore. It's really very much about the degree of tethering, the degree of right ventricular remodeling. When this is not too extreme, then you will be successful in most cases. And this is very much in line to what our surgical colleagues experienced also with tricuspid valve repair. As soon as tethering is beyond a certain stage, then repair is not very successful.
Thank you very much. Christian, you show us the follow-up of your patient after therapy. They have been bones treated now.
Exactly. So maybe we can show the patient characteristics again on the screen, just to remind you of both cases. It's highlighted up there. So the first patient was discharged 2 days after the procedure, and we have a follow-up up until 1.5 years. TR was reduced from massive to grade 1, so mild, and this was stable on echocardiographic follow-up with a mean gradient, transvalvular gradient 2.1. The rate atrial volume index slightly decreased, and also the basal right ventricular and the diastolic diameter was lower on follow-up. From a symptomatic point of view, this patient still had very mild peripheral edema, but her physical capacity increased, so her 6-minute walk distance improved, and she had symptomatic improvement and was in New York Heart Association class 2 after 1.5 years of follow-up. Importantly, there were no heart failure hospitalizations during this time, stable renal function, and the dose of her diuretics, remember she was on 40 milligrams of toracemide, was reduced to 25 milligrams. So that's the clinical course of patient number 1, and patient number 2 was also discharged 2 days after the procedure. TR was reduced from torrential to moderate. Again, stable results on echocardiographic follow-up. He was in stable New York Heart Association class 2 up until the last follow-up after 1 year. No heart failure rehospitalizations in this case. His renal function slightly improved with an EGFR from initially 22 to 30 milliliters per min on follow-up. And the parameters of liver congestion, remember, gamma GT and AP decreased. And on the last follow-up, after 1 year, congestion was well controlled in these patients with 60 milligram of toracemide, still a dose, but remember, he was on an MRI as well. The MRI was stopped, and but from a clinical point of view, again, congestion was well controlled. That was the clinical course of the second patient. So maybe we can draw. I'd just like to make one point. So maybe we can have some conclusions or some learnings from these patients. I think both cases show that the TR patient population is heterogeneous. We have different phenotypes. We've seen different phenotypes in terms of anatomy, etiologies, and disease stage. And they also highlight that the decision to intervene and the timing for intervention needs to be individualized, taking into account the symptoms of the patients, the response to the medical treatment, so to diuretics, of course, the feasibility and efficacy in a given tricuspid anatomy, and the expected clinical benefit from symptomatic point of view, physical functioning, quality of life, and prognosis. But as we've learned from these cases, from both cases, TriClip procedure is a safe and effective therapy, and in both cases, it helped the patients with limited treatment options to live a better life.
Thank you very much, Christian, very clear. And we need to conclude. Unfortunately, I think we could continue the discussion for hours. Thank you very much to everybody. I think we learned about the heterogeneity of the disease. We learned also from your cases, Christian, that independently of the reason for TR and the timing for treatment, you had an improvement in terms of quality of life, which is an extremely important improvement for our patient. Of course, we will need further study, and Paul, of course, I know you will continue to generate evidence on tricuspid valve disease to understand better which patient may benefit even more of this treatment. Thank you very much for your attention.